Welcome to Clinical Anatomy for PA students. Today we're going to talk about the pelvis and perineum. The pelvis is kind of divided into the greater pelvis or false pelvis, and then the lesser pelvis, which is the actual true pelvis. The pelvic cavity is down in the lesser pelvis or the true pelvis, which is a smaller inferior region. If you look over here at this picture on the right, on the top, you'll see this kind of like green area. That's the greater pelvis or false pelvis. It's essentially the area that's all inside the pelvic bones. So all inside the hips and the pelvic bones, the sacrum, that's all referred to as the greater pelvis. But the pelvic cavity is down in the true pelvis. And the true pelvis is this area here in yellow, the smaller, more inferior portion. The pelvis is part of the trunk, and it's the part of the trunk that's inferior and slightly posterior to the abdomen. The pelvis acts as a transition area between the trunk and the lower extremities. The abdominal cavity continues inferiorly into the pelvic cavity through an entryway or an aperture called the pelvic inlet. It's also referred to as the superior pelvic aperture, right? The passageway into the pelvis that's on the top. There's also an inferior pelvic aperture that's the exit from the pelvis. The superior pelvic aperture or the pelvic inlet is the border of the lesser pelvis, the top border around the lesser pelvis. It's formed by the linea terminalis of the pelvis. The linea terminalis is shown by this red line right here. We'll see it on the next page, but essentially it curves around from the anterior portion of the promontory of the sacrum, and it makes its way around to the top of the pubic pelvis, or sorry, the top of the pubic symphysis as well. But the red line is the linea terminalis, and that line marks the top of the true pelvis, and also the hole through it, or the passageway through it, is the pelvic inlet. The pelvic outlet, or inferior pelvic aperture, is the bottom of the lesser pelvis, or bottom of the true pelvis. If you will, it's the exit out of the pelvis. And this is limited, the inferior portions of the pelvis, or the pelvic outlet, is limited by the pelvic diaphragm, which is a muscular wall that contains the levator ani, which is a muscle we'll look at a little bit later. But if you look down here at the bottom picture, you see the whole abdominal pelvic cavity right below the diaphragm. And in pink is the actual pelvic cavity. So you see the pelvic cavity actually extends down to the pelvic inlet at the very top of the lesser pelvis or true pelvis. So this area is within the bony pelvis, right? The bony pelvis comes up like this. So this area is within the bony pelvis, but it's actually part of the abdominal cavity. That's what we would refer to as the greater pelvis or false pelvis. The lesser pelvis or true pelvis, again, is from the linea terminalis down to the pelvic diaphragm, which is this kind of cone-shaped muscular diaphragm right here. And then the area inferior to that is the perineum, which we'll also talk about today. Here you can see the specific borders of both the pelvic inlet and the pelvic outlet. In this first picture here, we're looking at a superior view of the pelvis to see the pelvic inlet. And then over on this side, we're looking at an inferior view of the pelvis to see the pelvic outlet. The borders of the pelvic inlet are anteriorly the symphysis pubis or pubic symphysis. And it's important to know that we're talking about the superior surface or top surface of the symphysis pubis or pubic symphysis. Posteriorly, the border is the promontory of the sacrum. So the very anterior-most part of the promontory of the sacrum. And then also kind of curving out from that, the ala, the wings here, the ala of the sacrum. Laterally, the walls are formed by the iliopectineal or arcuate lines. Sorry, iliopectineal or arcuate lines. And the arcuate lines are like arcs, right? They just curve around the sides of the pelvis right here and right here. And on the actual pelvis, you'll see that there are little like ridged lines that arc around there. The pelvic outlet, which you can see here, which is again the bottom of the pelvis, is formed by the pubic symphysis anteriorly. But now we're talking about the inferior border or bottom of the pubic symphysis. Posteriorly is the coccyx, the specific tip of the coccyx, which you see right here. And then the bottom of the pubic symphysis is up here. Anterolaterally, it's the ischiopubic ramus. The ramus is this, like this wall of the pelvis. And then posterolaterally, the sacrotuberous ligament. And you see the sacrotuberous ligament here and here. Sacrotuberous, like sacrum to the tuberosity. Specifically, it's the ischial tuberosity, but so sacrotuberous, sacrum to the tuberosity. The perineal region is the inferior-most region of the trunk. It's the area between the thighs and back to the buttocks, or posterior to the gluteal cleft of the buttocks. It extends from the pubis to the coccyx, so from the pubic symphysis in the front back to the coccyx in the back. The perineum refers to the shallow compartment that's just deep to this perineal region, but inferior to the pelvic diaphragm. So essentially, we just looked at the pelvic outlet. From the pelvic outlet down until we actually leave the trunk, till the surface of the body, is the perineum. Over here, you can see the general region. In blue here, this was the lesser pelvis, and the pelvic outlet was here at this pelvic diaphragm. So just inferior to that pelvic diaphragm, this area here that's shaded orange, this is the area that's referred to as the perineum. Here you can see the specific anatomical borders. Again, the anatomical borders are the same exact borders that we used for the pelvic outlet. Right? The pelvic outlet was from the pubic symphysis back to the coccyx. Right? And then we had our rami, and then the sacrotuberous ligament and sacrotuberous ligament. So the pelvic outlet is the entrance into the perineum. Here you see actual surface borders. On either side, we have the medial surface of the thigh. In the front, the mons pubis, which is just the protrusion over the pubic bone. And then in the back here, we see the intergluteal cleft, which is the cleft in between each of the butt cheeks, if you will, intergluteal between the gluteus maximus on each side, or the gluteal muscles on each side. So you see this happens to be in a female, but in a female, it includes the clitoris in the front, the urethra, which would be just inferior to that. It includes the entrance into the vagina. It includes the anus as well. There are structural differences in the bony pelvis between the sexes. And these have evolved over time because obviously there are major differences between the male body and the female body, both structurally and functionally. Men tend to have a heavier build and stronger musculature, so the bones need to be strong with good bone markings for muscle attachment. Women are generally smaller, but women endure the process of childbirth, and the pelvis happens to be incredibly important for childbirth. So the pelvis is structured in a way to facilitate the birth or the passage of the infant through the birth canal. The male pelvis is heavier and thicker in general. The bones are thicker with more prominent bone markings. Bone markings are important for muscle attachment. When we look at the male pelvis, the pelvic inlet tends to be more heart-shaped in men. So it's more heart-shaped like this, and that presents for a pretty narrow passageway for a fetus to pass through. Right, this narrowest point of this is much too narrow for a baby to pass through. In a woman, we'll see that the pelvic inlet is more oval-shaped, so there's not that one narrow point in the middle that would interfere with an infant passing through the birth canal. When looking at the pelvis and deciding if it's male or female, kind of surefire way to decide is to look at the subpubic angle. The subpubic angle is the angle underneath the pubic symphysis. So think about it, you have a pubic bone, and then fibrocartilage pad, and then another pubic bone, and then the bones kind of go down like this. Sorry. This angle right here is the subpubic angle. So in men, that subpubic angle is narrow. It's about the angle between the forefinger and middle finger, the pointer finger and middle finger. If you spread those two fingers, this angle is about the angle of the male subpubic angle. The female pelvis tends to be lighter and shallower and wider. It's not so tall and narrow. It's more bowl-like. It also has a larger inlet and outlet, which again is important for passage of an infant during childbirth. Again, we said that the pelvic inlet is more oval-shaped in the female pelvis, and the subpubic angle is much wider. It's more like the thumb and forefinger. So if you look at this angle right here, that's a much wider angle than this. Also, the acetabulum, which is the hip joint. So the head of the femur fits into the acetabulum. This is smaller in women, which makes sense if you think that males have a larger build, larger bone structure, larger hip joint. That makes sense that the female acetabulum would be smaller. Here you can see the male and female pelvis. This top picture is showing you the shape of the pelvic inlet. We said in men, the pelvic inlet is more heart-shaped, and in women, it's wider and more oval-shaped. And it's really easy to look at this and see which one would form a wider birth canal, or which one would be easier for an infant's head to pass through, rather. And this is much larger, whereas it's too small for an infant to pass through. Also, if you look over here, you can see the subpubic angle, or this says pubic arch, but the pubic arch is the actual bone structure, like the arch of the bone that's the pubic arch. That's the pubic arch. The angle itself is the subpubic angle. So really they're talking about the same thing. It's just kind of technically different. You can see in the man, it's a really tight angle, right? And in the female, it's a lot wider angle. During labor, the fetal head must pass through the pelvic inlet to enter the lesser pelvis during labor. And this is where the narrowest part of the body is that the fetus or infant has to pass through. The minimum anteroposterior diameter, or the narrowest point that the baby has to pass through, is referred to as the true conjugate or the obstetrical conjugate. This true conjugate, or this narrowest point, is from the middle of the sacral promontory, right, which runs from the sacrum, there's the ala or the wings, and then the base, and the base has this like curved part on the front. That's the sacral promontory. So from the anteriormost point, which is the middle of that sacral promontory, down to the, or anterior, into the pubic symphysis. That is the obstetrical conjugate or the true conjugate. Now, so that's the narrowest point, and that has to be at least 11 centimeters. So we need at least 11 centimeters there for the infant to be able to fit through the birth canal. However, the true conjugate or obstetrical conjugate can't be measured during a pelvic exam. What you can measure during the pelvic exam is the diagonal conjugate. So we use the diagonal conjugate and then convert that to the true conjugate to measure, to make sure that there's enough distance for the infant to be born vaginally. To find the diagonal conjugate during a vaginal exam, you palpate the sacral promontory with the tip of the middle finger, and then use your other hand, your free hand, to mark the level where the inferior margin of the pubic symphysis is. So palpate the sacral promontory with the tip of the middle finger, and then mark wherever the pubic symphysis is, the inferior border of the pubic symphysis is, on that examining hand. And then withdraw the hand and you measure the distance from where you marked, but you don't measure from the middle finger. From the middle finger to the mark, that would be the diagonal conjugate. Okay, but for the true conjugate is actually shorter than that. The true conjugate is about 1.5 to 2 centimeters less than the true conjugate. So when you're measuring, instead of measuring the diagonal conjugate, you just measure from the pointer finger. If you measure from the pointer finger down to the mark, that will give you the approximate true conjugate. And if you look at your fingers, it kind of makes sense. Your pointer finger is a little bit shorter than your middle finger. So that takes into account the fact that the true conjugate is actually a little bit less than the diagonal. So instead of measuring the diagonal and then subtracting from it, you just measure from the pointer finger down to the marked spot. Here you can see this. So here again, you can see, so here's your sacrum, right? And fingers going in with the middle finger to palpate the anterior border of the sacral promontory. And then once she is palpating the sacral promontory, you can see with the other hand, she's marking the exact point where the inferior border of the pubic symphysis is. And here you can see the pubic bone right here, right? So right here. And then taking that out, then she would actually just measure from this point, and that would give the actual accurate, because this is the true distance that you can see that the infant has to pass through. That's the shortest distance. What she's measuring is that. Let me erase this. The true shortest point is like this. What's getting measured is more like this, which is longer. So measuring, when the hand is withdrawn, measuring from the pointer finger instead of the middle finger takes away some of that extra length. And here you can see that, right? So from the sacral promontory, which is right here, and then this is the pubic bone, right at the pubic symphysis. The shortest point is right here. That's the obstetrical or obstetric or true conjugate. You can't measure that point, but what you can mark and measure is right here. And then that gets measured. But again, if you measure from the pointer finger instead, it's the same distance. I hope that made sense. Here you see the primary ligaments that are involved with the pelvic girdle or the bones of the pelvis. The anterior sacroiliac ligaments are shown here. They're these large, broad ligaments that are between the sacrum in the middle and then the ilium on either side. The interosseous sacroiliac ligament is an internal ligament back here. These are really large ligaments. They're like 10 centimeters or so each. And these are the primary ligaments that are involved in transferring the weight of the upper body and or the arms and the trunk to the pelvis, and then transferring that weight down to the femur when standing, and then to the ischial tuberosity when sitting. The ischial tuberosity is like the butt bone that you feel when you sit down. The posterior sacroiliac ligaments are just posterior continuations of the interosseous ligaments. So like here you see the posterior sacroiliac ligaments continuing posteriorly. And again, from the sacrum to the ilium, which you see here. The sacrotuberous and sacrospinous ligaments are both involved in making sure that the sacrum doesn't rotate anteriorly. And it gives strength to that sacroiliac joint when there's a sudden increase in weight on the vertebral column. So when the weight pushes down the vertebral column, that force gets transferred to the sacrum and just the sacrum, right? So the sacrum doesn't want to rotate anteriorly from the joint with the ilia on each side. This can happen like when you jump from a really high height or are lifting a really large weight, for example. The sacrospinous ligament is right here and right here. And then you can see it better in the front, here and here. The sacrotuberous ligament kind of crosses it. From the front, you can see it back there and back there. Sacrotuberous, like from the sacrum to the tuberosity, the ischial tuberosity. That's easiest to see back here, though. So here and here. The iliolumbar ligament technically isn't part of the sacroiliac joint. It's not one of the sacroiliac ligaments. That's part of the iliolumbar, the lumbosacral joint. So if you look here, the lumbar vertebrae, and the way that the lumbar vertebrae form a joint with the sacrum. So specifically L5 forming a joint with the sacrum. The iliolumbar ligaments stabilize that joint. So iliolumbar sounds like it's involving the ilium, but really the iliolumbar ligaments, they connect to the ilium. But the joint that they're stabilizing is actually the lumbosacral joint. So the iliolumbar ligament, along with the intervertebral disc between L5 and S1, help to stabilize that lumbosacral joint. So the rest of these are ligaments of the sacroiliac joint. The pubic symphysis is this joint that you see right here, where the two pubic bones come together. So this is the pubic bone of the pelvis, pubic bone of the pelvis. Where they come together is the pubic symphysis. You see a nice thick fibrocartilage disc in between. It's called the interpubic disc right here. And then there's a superior pubic ligament and an inferior pubic ligament. The superior pubic ligament is here, and then the inferior pubic ligament is down here. The inferior is also called the arcuate ligament, and you can see why, right? It's more of an arc shape. You'll also notice the pubic crest, right? Here and here. The pubic tubercle, little process that sticks out. The obturator foramen is really important. We'll talk about the obturator foramen a little bit later. We'll talk about the obturator nerve and the obturator membrane. That will come into the conversation a little bit later. During the second half of pregnancy, there's a great increase in sex hormones, but also the hormone relaxin. And just like it sounds, relaxin causes relaxation. It relaxes the pelvic ligaments, and this increases the flexibility and movement that's allowed in the pelvis. It allows for greater rotation and for the coccyx to move posteriorly. When the coccyx moves posteriorly, this allows for more room in the pelvis. And overall, there's a 10 to 15% increase in diameter, and that's mostly an increase in transverse diameter. But the increase in diameter allows for easier passage of the infant through the pelvis. This is why you see that typical lordotic posture that's seen late in pregnancy. The walls of the pelvis are formed by the bones of the pelvis, and then also fascia and muscles. And the muscles that form the walls of the pelvis include the piriformis and the obturator internus. The pelvic floor, which is a bowl or kind of funnel-shaped structure, is formed by muscles and their fascias, and we refer to these muscles as the pelvic diaphragm. This pelvic diaphragm is made up of the coccygeus muscles. The coccygeus muscles extend from the sacrum and coccyx to the ischial spines, which are little protrusions on the ischium, the posterior lateral portions of the pelvis. And then the majority of the pelvic floor is formed by the muscles that form the levator ani. There are actually three parts, or three muscles that are involved here: the puborectalis, the pubococcygeus, and iliococcygeus. And the names are pretty specific for where they are and their connections. Here you see the pelvic floor, so the pelvic walls and pelvic floor. To get your bearings where you're looking down into it. So like the pelvis would be on inside this, and you're looking at the very bottom, the very floor of it. So this is the back here, right? The sacrum. You see the sacral body and the promontory. The coccyx is kind of curling forward underneath here. And then you see the ilium, the ischium is kind of coming down underneath, the pubis coming forward, and the pubic symphysis at the front, this is the back, and we're looking down into it. So the piriformis and the obturator internus are coming up at us, and they're forming the walls of the pelvis, the pelvic walls. So the piriformis back here is forming the posterior lateral wall. And then the obturator internus is coming up along the anterolateral wall. Then in the back of the pelvic floor is the coccygeus. So again, this little kind of triangle right here is the coccyx. right? So the coccygeus going out, and then the rest of these muscles here, both of these like areas on either side are showing us the muscles of the levator ani. The levator ani includes the puborectalis as the medialmost muscle. So the puborectalis that attaches to the pubic bone goes around the rectum and then comes back to the pubic bone, hence puborectalis. The pubococcygeus goes from the pubic bone, that's more lateral to the middle one, from the pubic bone back to the coccyx bone. And then the iliococcygeus comes from the ilium back towards the coccyx. Here we just have more details about the muscles that form the levator ani. The puborectalis is the major structural part that's important in maintaining fecal continence or keeping the feces from leaking out of the body until we're ready to release them. It's a continuous U shape that attaches to both the left and right pubic bones, and it extends posterior to the anorectal junction, or the area where the anus meets with the rectum. The pubococcygeus is the intermediate part of the levator ani. It extends from the pubic bone and tendinous arch anteriorly, and then back to the coccyx. Back to the coccyx posterolaterally. And then posteromedially, the fibers actually like come and merge with each other. So where do I have it? Medial fibers merge with those of the contralateral side, and that forms part of the anococcygeal body, or the area between the anus and the coccyx. The iliococcygeus is the posterolateralmost part of the levator ani. It extends from the posteriormost part of the tendinous arch and the ischial spine, and then it blends with the anococcygeal body back here posteriorly. And this is thin, often underdeveloped portion of the levator ani. So here we can see all of that pelvic floor. So just to get your brain, this is posterior and this is anterior. So it's kind of flipped from before. Looking at them, this is the obturator, write it, obturator internus. I don't know if that's ER or OR, obturator, I think it's OR. The obturator internus forms the lateral walls anteriorly. Anterolaterally forms the walls, and then posterolaterally the walls are formed by the piriformis. Then the floor, posteriorly, the floor is formed by the coccygeus muscles. And then the rest of the muscles here are part of the levator ani. This kind of white area up here, this is the tendinous arch that we keep talking about, the muscles connecting to. And technically, it's the tendinous arch of the levator ani. So we have the, okay, puborectalis, so this is the front. So the puborectalis is the U shape. So like that is the puborectalis. And then the pubococcygeus goes back, and the lateralmost fibers connect to the coccyx. Pubococcygeus. And then you can see how the two sides blend with each other right here. And then finally, the iliococcygeus is the lateralmost portion. So like this part out here. Is the iliococcygeus. The levator ani is important in one, providing inferior support to the pelvic or abdominal pelvic viscera, and then contraction of the levator ani raises the pelvic floor. And raising the pelvic floor prevents the release of any pelvic contents. So it prevents the release of gas or feces or urine. The pelvic floor is allowed to relax and lower during defecation or urination. So after defecation or urination, the pelvic floor contracts and that, the levator ani contracts, and that raises the pelvic floor back to its normal position to prevent the release of any more feces or urine. Also, there are times when abdominal pressure increases and the levator ani contracts to prevent the release of gas or wastes when that abdominal pressure increases. Abdominal pressure increases when we breathe, right? When the diaphragm pushes down into the abdomen. Also, when the abdominal wall muscles contract, that increases the pressure in the abdomen and pelvis, and contraction of the levator ani keeps the pelvic floor raised so that we don't accidentally release gas or feces or urine when that abdominal pressure increases. The levator ani contracts automatically or reflexively during coughing, sneezing, any forceful movements like picking up something heavy or jumping. And that's again to prevent the accidental release of wastes. The perineum, the pelvic floor muscles like the levator ani and the pelvic fascia can all be injured during childbirth. While the cervix dilates, the infant's head is being supported by the pelvic floor, and this can stretch or tear the muscles that form the pelvic floor, the fascia that helps to form and support the pelvic floor. The pubococcygeus, which remember is the intermediate muscle of the levator ani, is the most frequently torn of the three muscles of the levator ani. Any weakening of these muscles from stretching or tearing during childbirth can end up altering the position of the neck of the bladder, and altering this positioning can relate or can result in urinary stress incontinence. This is an incontinence when there's any stress in the area, i.e. increase in pressure. So dribbling of urine or slight urine leakage when intra-abdominal pressure increases suddenly. So this is like during coughing or sneezing, jumping, or lifting. And this is relatively common after pregnancy for this to happen. And doing daily contractions, we call them Kegels, but doing daily contractions, the muscles can help to prevent this or re-strengthen the muscles after childbirth. Also, this does put a patient at an increased risk of pelvic organ prolapse. Which is a prolapsing or a falling out of pelvic organs. The sacral plexus refers to the group of nerves that come from the sacral nerves, the sacrospinal nerves. The sacral plexus descends on the posterolateral wall of the pelvis, just anterior to the piriformis muscle. The sacral plexus is joined by the lumbosacral trunk. The lumbosacral trunk, remember, is formed from fibers from the anterior rami of L4 and L5. Spinal nerves, hence being called lumbosacral. It originates in the lumbar region, but then descends down into the lesser pelvis or true pelvis and joins the sacral nerves or joins the sacral plexus. Most branches of the sacral plexus exit the pelvis through an area called the greater sciatic foramen. The greater sciatic foramen is a passageway in the lateral part of the pelvic outlet. And this, the passageway or the pelvic outlet is kind of broken up by the sacrospinous ligament. So the sacrospinous ligament goes from the sacrum to the ischial spine. And as it cuts across the pelvic outlet, it divides it up into sections. The lateralmost section is the greater sciatic foramen. So most branches of the sacral plexus exit the pelvis via the greater sciatic foramen on the lateral portions of the pelvic outlet. The major branches of the sacral plexus are the sciatic nerve and the pudendal nerve, which we'll talk about both of those in a moment. The superior gluteal nerve and inferior gluteal nerve are also present on the pictures that are coming up, but we won't talk about them in much detail. The superior gluteal nerve innervates the gluteus medius and gluteus minimus, as well as the tensor fasciolata, which is present on the lateral superior thigh or proximal thigh. The inferior gluteal nerve innervates the gluteus maximus. Here you see the nerves of the sacral plexus. This is the lumbosacral trunk right here. You can see it coming from the L4 and L5 spinal nerves. They merge and form the lumbosacral trunk, which comes down and merges with fibers of the sacral nerves to join the sacral plexus. This passageway right here is the greater sciatic foramen, the side of the pelvis right here, and then the sacrospinous ligament is this ligament right here. It extends from the ischial-spine anteriorly back to the sacrum posteriorly to form that little passageway, the little foramen that most of the nerves exit through. Let me erase. Looking at the nerves themselves, number 2 right here, that's showing us the inferior, or sorry, the superior. The inferior is not shown on this picture, but that's the superior gluteal nerve. So over here, this is the superior gluteal nerve, and then the inferior gluteal nerve is 3. Number 1 is showing us the sciatic nerve. So you can see the sciatic nerve is huge, passing out through the greater sciatic foramen. So number 1 is the sciatic. Pudendal is this one that comes down right here. It's number 7. It's the pudendal. So I said that we would talk a little bit more about the 2 largest nerves of the sacral plexus, the sciatic nerve and the pudendal nerve. The sciatic nerve is actually the largest nerve in the body. It's formed from the anterior rami of L4 through S3. It's formed as the nerves merge along the, or fibers merge along the anterior surface of the piriformis. And then it passes from the pelvis into the gluteal region through the greater sciatic foramen. There's a C in here. SCIATIC, greater sciatic foramen. This is the nerve when there's nerve damage to the sciatic nerve. The patient normally talks about a shooting pain down their butt in the back of their leg. This is because the sciatic nerve extends down the butt and the back of the leg. And that's going to happen when there's damage to the spine, even in the lumbar region, because the nerve fibers are coming up all the way from L4. So it seems weird that the pain is in the butt and in the thigh, but that's because that's where the sciatic nerve goes. And that's typically the description of nerve pain, right? It's a shooting pain or like electric lightning type pain. We'll talk about that when we talk about the leg, though. The sciatic nerve innervates the hip joint, the flexors of the knee, which are the hamstrings on the back of the thigh, and then all muscles in the leg and foot. The pudendal nerve is formed from the anterior rami of S2 through S4, so S2, 3, and 4. It actually exits the pelvis through the greater sciatic foramen, and then it hooks around the ischial spine and enters the perineum via the lesser sciatic foramen. So it goes out through the greater sciatic foramen, hooks around, goes in through the lesser sciatic foramen and into the perineum. It's the main nerve of the perineum. It provides both motor and sensory fibers to the perineum. And the motor fibers control the external urethral and anal sphincters. So the pudendal nerve is responsible for controlling the release of urine and feces, or voluntary control over the release of urine and feces. So bladder control and bowel control is via the pudendal nerve and comes from the S2 through S4 spinal segments or spinal nerves. Here again, you guys can see that the sciatic nerve we said was 1 right here, and you can see it exiting through the greater sciatic foramen. You can also see that it comes from L4, L5, S1, S2, and S3. The pudendal nerve is 7 right here. You can see it comes from S1, 2, and 3, or sorry, S2, 3, and 4. Yeah, so pudendal is, sorry, S2, S3, and S4. And you can see it coming, so 2, 3, 4. It comes out through the greater sciatic foramen and then wraps around the ischial spine. Okay, this is the ischial spine right here. So now you can see that right there, wrapping behind the ischial spine and then coming in, and then it goes to the perineum. During childbirth, the infant's head might temporarily compress the sacral nerve plexus. This typically results in pain in the lower limbs due to the sciatic nerve innervating the lower limbs. The obturator nerve, which traverses down the lateral pelvic wall, is vulnerable to injury during surgery that involves that area. For example, removing lymph nodes from the lateral pelvic wall can damage the obturator nerve. When the obturator nerve is damaged, this results in painful spasms of the adductor muscles of the medial thigh, as well as sensory deficits in the medial thigh region.